This presentation is on teaching, Chapter 8 in TIMBY, and Chapter 43 in Concepts. Learning objectives. Identify the authoritative bases that mandate client teaching. List examples of client teaching provided by nurses. List 5 benefits that result from client teaching. Describe the 3 domains of learning. Discuss 3 age-related categories of learners. Discuss at least 5 characteristics unique to older adult learners. Identify at least 4 factors that nurses assess before teaching clients. Teaching is one of the most important uses of communication for nurses. Health teaching promotes the client's independent ability to meet his or her health needs. An old proverb that reinforces how education promotes self-care says, "Give a man a fish and he will eat for a day. Teach a man to fish and he will eat for a lifetime." Teaching is an essential nursing responsibility when caring for clients in a healthcare agency, at home, or in community settings. This chapter offers information on principles of teaching and learning. Importance of client teaching. Health teaching is a mandated nursing activity. State Nurse Practice Acts require health teaching, and the Joint Commission, as of 2010, has made it a criterion for accreditation. Likewise, the American Nurses Association Social Policy Statement from 2010 addresses it with the following statement: nurses partner with individuals, families, communities, and populations to address issues such as the ... promotion of health and wellness ... and health literacy. Limited hospitalization time demands that nurses begin teaching as soon as possible after admission. Early attention to the client's learning needs is essential because learning takes place in 4 progressive stages. Recognition of what has been taught, recollection or description of information to others, explanation or application of information, independent use of new learning. Client teaching generally focuses on combinations of the following subject areas: the plan of care, treatment, and services, safe self-administration of medicine, the pain assessment process and methods for pain management, directions and practice in using equipment for self-care, nutrition and dietary instructions, rehabilitation programs, available community resources, plan for medical follow-ups, signs of complications and actions to take. Some of the benefits of client teaching include reduced length of stay, cost effectiveness of healthcare, better allocation of resources, increased client satisfaction, and decreased readmission rates. A delay in teaching slows optimum learning outcomes. If teaching standards are not met and discharged clients are readmitted or harmed because they were uninformed or failed to understand information that was taught, nurses are at risk for being sued. The best proof of adherence to teaching standards is to document in the client's medical record who was taught, if it was other than the client, for example, the spouse or caregiver, what was taught, the teaching method, and the evidence of learning. Hospitals are asking clients to sign a duplicate of their discharge instructions, the information that is essential for promoting safety during the initial post-hospital period. There are 4 progressive stages of learning: recognition of what has been taught, recall or description of information to others, explanation or application of information, and independent use of new learning. Is the following statement true or false? Style of learning means how a person responds to learning. False. Style of learning means how a person prefers to acquire knowledge. Assessing the learner. To implement effective teaching, the nurse must determine the client's preferred learning style, age and developmental level, capacity to learn, motivation, learning readiness and learning needs, and cultural differences. Learning styles. 3 general domains: A client's learning style means how a person prefers to acquire knowledge. Learning styles fall within three general domains: cognitive, affective, and psychomotor. The cognitive domain is a style of processing information by listening or reading facts and descriptions. The affective domain is a style of processing information that appeals to a person's feelings, beliefs, or values. The psychomotor domain is a style of processing information that focuses on learning by doing. One way to determine the client's preferred learning style is to ask a question such as, when you learned to add fractions, what helped you the most? Hearing the teacher's explanation or reading about it in a mathematics book, which is cognitive, recognizing the value of the exercise, affective domain, or actually working sample problems, which is psychomotor domain. Although most clients favor one domain, nurses can optimize learning by presenting information through a combination of teaching approaches. Although the following figures, which originated in the National Training Center's Institute for Applied Behavioral Sciences in Alexandria, Virginia in the 60s, has been challenged, it is proposed that, quote, learners retain 10% of what they read, 20% of what they hear, 30% of what they see, and 50% of what they see and hear, 70% of what they teach, talk, and 90% of what they talk and do. The bottom line is that learning improves when there is more active involvement. How children and adults learn. Children rely on others to decide what is important to be learned. They accept the information being presented at face value. They expect what they are learning to be useful in the future. They have little or no experience upon which to draw. They have little ability to serve as a knowledgeable resource. They encourage convergent thinking. They use specific concrete thought. Rote learning is used, subject-centered, and motivated by external environments and rewards and punishment. Adults decide for themselves what it is important to be learned, need to validate the information based on experience. They expect what they are learning to be immediately useful. They have much past experience to draw, significant ability to serve as a knowledgeable resource. They encourage divergent thinking. They use generalized abstract thought. They are active learners. They are task or problem-centered, motivated internally, and the incentives by their own incentives or curiosity. Cognitive domain. The cognitive domain addresses intellectual skills involved in learning. It is the foundation for learning because the remaining domains are integrated with a cognitive component. There are various levels of intellectual skills within the cognitive domain, progressing from the very basic level of thinking to the more advanced. Benjamin Bloom and his colleagues identified the cognitive levels in 1956. Although the original was a collaborative effort, they have since been referred to as Bloom's taxonomy, which is a classification system. In 2001, Anderson, one of Bloom's former students, and Krathwohl, one of Bloom's original co-authors, revised and rearranged the original taxonomy, changing nouns to verbs. The old version and the new version can be seen on page 109 in concepts and on this slide, the old version, orange, and the new version, green. Application of the cognitive domain to the National Licensing Examination. Test questions on the National Licensing Examination and NCLEX are classified according to their level of difficulty, which coincides with Bloom's taxonomy. Passing the examination depends on both the number of correctly answered questions and their level of cognitive difficulty. Remembering, the lowest level of cognition requires recalling information from prior memorization. Understanding, the next level, requires explaining ideas or concepts. Applying, the cognitive level at which the majority of NCLEX, PN, or BN items are written, requires using principles to solve or interpret information related to a client's health or its deviations. Analyzing, a cognitive level of further increasing difficulty, requires using abstract and logical thought processes that form the basis for a nursing action. This level of thinking necessitates, for example, that a person compare or contrast information, distinguish cause and effect, identify differences, and question actions. Evaluating, the next step to highest cognitive level, involves an ability to appraise a situation or information and to defend or support a selected action. Creating, the highest and most challenging degree of thinking, requires activities such as inventing, modifying, substituting, and reorganizing information to fashion new ideas. The cognitive level is identified for each NCLEX-style question that appears at the end of chapters in this text. Affective domain. Krathwohl and others in 1973 further expanded learning into affective levels based on feelings and emotions. The levels within the affective domain are similarly arranged from simple to complex. The focus in this domain includes motivation to learn, valuing what is learned, and incorporating learning into one's life. Learners are characterized as 1. Willing to listen or receive, 2. Willing to participate or respond, 3. Accept or committing to new information, valuing, 4. Integrating the new information by changing behavior or organization, and 5. Continuing to practice and act upon acquired information, which is called characterization. Psychomotor domain. Several others have independently compiled evidence of learning within the psychomotor domain that describes how a physical skill develops. Depending on the author, the identified levels vary from a detailed progressive list to others that are more concise. For the purposes of simplicity, Bixler in 2007 developed the following representative summary of levels within the psychomotor domain. Observing involves watching an experienced person perform a physical skill. Imitating describes the learner's attempt to duplicate the observed skill. Practicing, the act of performing a skill repeatedly. And adapting, making minor changes in the performance of the skill when adjustments are necessary. This tier of actions describes how nursing students and others progress from novice to skilled practitioners. Table 8.1 on page 109 lists some activities associated with each learning domain. Cognitive is listening, identifying, locating, labeling, summarizing, and selecting. Affective is advocating, supporting, accepting, promoting, refusing, and defending. Psychomotor is assembling, changing, emptying, filling, adding, and removing. Age and developmental level. Educators emphasize that learning takes place differently depending on a person's age and developmental level. Developmental level refers to physical, cognitive, social, emotional, and language characteristics that are norms at particular stages in life, from infancy through adulthood. Experts agree that teaching tends to be more effective when it is designed to accommodate unique age-related differences. Recently, a distinction has been made between learners at the early and later ends of the aging spectrum. Currently, there are 3 major categories. Pedagogy is the science of teaching children or those with cognitive ability comparable to children. Andragogy is the principle of teaching adult learners, and gerontology is the unique techniques that enhance learning among older adults. Nurses and all those who provide health teaching must be aware of the learning characteristics of children, adults, and older adult learners. Although most clients with health problems are in their later years, nurse educators are advised to prepare themselves to teach adults who belong to Generation X, Generation Y, and Generation Z as they age. Generation X refers to those born between 1961 and 1981. Generation Y, millennials, refers to people who were born after 1981 through the latter part of the 20th century. And Generation Z, the net generation or cyber kids, refers to those born at the beginning of the 21st century. In general, those who represent generations X, Y, and Z may share many learning characteristics. They are or will be technologically literate, having used or grown up with computers, smartphones, and tablet devices. They crave stimulation and quick response. They expect immediate answers and feedback. They become bored with memorizing information and doing repetitious tasks. They prefer a variety of instructional methods from which they can choose. They respond best when information is relevant. They appreciate visualizations, simulations, and other methods of participatory learning. Is the following statement true or false? Andragogy refers to the principles of teaching adult learners. True. There are 3 major categories of learners at the early and later ends of the adult spectrum. The principles of teaching adult learners is known as andragogy. Pedagogy is the science of teaching children, or those with cognitive ability comparable to children. Gerontology consists of techniques that enhance learning among older adults. Unique Characteristics of young adults. Review. They are technologically literate, having grown up with computers. They prefer visualization, simulations, and other methods of participatory learning and quick response. They expect immediate answers and feedback. They become bored with memorizing information and doing repetitious tasks. They like a variety of instructional methods from which they can choose. They respond best when they find the information to be relevant. They become bored with memorizing information and doing repetitious tasks. They like a variety of instructional methods, and they respond best when they find the information to be relevant. Question: which do young adult learners prefer? A, memorizing information, B, repeating tasks, C, fewer instructional methods, or D, participatory learning? The answer is D, participatory learning. Young adult learners do not like memorizing information or repeating tasks. They prefer participatory learning using visuals and a choice of various instructional methods. On page 110 in TIMBY, Table 8.2, age-related differences among learners, you have descriptions of pedagogic learners, andragogic learners, and gerontologic learners. Also, capacity to learn. For the person to receive, remember, analyze, and apply new information, he or she must have a capacity to learn, that is, a certain amount of intellectual ability. Illiteracy, sensory deficits, cultural differences, shortened attention span, and lack of motivation and readiness require special adaptations when implementing health teaching. Gerontologic considerations. During an assessment, older clients may interact in a socially appropriate manner and may indicate that they understand the material being taught. Asking a client to recall what has been discussed after approximately 15 minutes have passed may help determine what information has actually been retained. A mental status examination may be indicated. If there is cognitive impairment, a support person or caregiver should be present for the teaching sessions. Literacy. It is essential to determine a client's level of literacy, ability to read and write, before developing a teaching plan. Approximately 32 million Americans cannot read at all. One could infer that these same adults are therefore illiterate. They cannot read or write. 14% of U.S. citizens read below a basic level. 20% of Americans are considered functionally illiterate. They possess minimal literacy skills, which means they can sign their name and perform simple mathematical tasks such as making change, but read at or below a 5th grade level. Functional illiteracy may be the consequence of a learning disability, not a below average intellectual capacity. Health literacy. Health literacy, the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions, is obviously a factor in client teaching. The latter affects a client's ability to locate health information, access healthcare services, share personal health information with professionals, analyze relative health risks and benefits, calculate drug dosages, evaluate information for credibility and quality, and interpret test results. Detecting health illiteracy. Because many illiterate or functionally illiterate people are not apt to volunteer information about their reading problems, literacy may be difficult to assess. Some indications that clients have low health literacy are missed appointments, incomplete health forms, non-adherence to medication regimen, unable to provide a coherent health history, and lack of follow-up on tests and referrals. Those who are illiterate and functionally illiterate usually develop elaborate mechanisms to disguise or compensate for their learning deficits. To protect the client's self-esteem, the nurse can ask, "How do you learn best?" and plan accordingly. Is the following statement true or false? A client with minimal literacy skills is termed functionally literate. False. A client with minimal literacy skills is termed functionally illiterate. Capacity to learn. Studies have shown that 40 to 80% of medical information clients receive is forgotten immediately, and nearly half of the information that is retained is incorrect. Some useful approaches for promoting health literacy include using verbal and visual modes for instruction, avoid technical language, limit information to 3 to 5 points, be specific rather than general, repeat directions several times in the same sequence so that the client can memorize the information, provide pictures, diagrams, audio recordings, and videos for future review. Some advocate using the teach-back method to determine if teaching has been effective. The teach-back method is a technique for confirming that a client has understood what has been taught by asking the client to repeat the information in their own words. It can be considered a form of feedback. For example, the nurse can say, "I want to be sure that I explained your medication correctly. Can you tell me how you are going to take this medicine?" Sensory deficits. The abilities to see and hear are essential for almost every learning situation. Older adults tend to have visual and auditory deficits, although such deficits are not exclusive to this population. Nursing Guidelines 8.1 presents some techniques for teaching clients with sensory impairment. Figure 8.3 shows samples of printing that can be used as visual aids. Cultural differences. Because teaching and learning involve language, the nurse must modify approaches if the client cannot speak English, or if English is a second language. Language barriers do not justify omitting health teaching. In most cases, if neither the nurse nor the client speak a compatible language, a translator or acceptable alternative is needed. Attention and concentration. The client's attention and concentration affect the duration, delivery, and teaching methods employed. Some helpful approaches include the following. Observe the client and implement health teaching when he or she is most alert and comfortable. Keep the teaching short. Use the client's name frequently throughout the instructional period. This refocuses his or her attention. Show enthusiasm, which you are likely to communicate to the client. Use colorful materials, gestures, and variety to stimulate the client. Involve the client in an active way. Vary the tone and pitch of your voice to stimulate the client orally. Teaching clients with sensory impairments. Ensure that the client with a visual impairment is wearing prescription eyeglasses, or that the client with a hearing impairment is wearing a hearing aid if available. Gerontologic considerations. A calm demeanor and a quiet environment can decrease anxiety or distractions that interfere with learning. Peer teaching or reinforcement in support group settings may be helpful. Motivation. Learning is optimal when a person has motivation, that is, a purpose for acquiring new information. Relevance of learning depends on individual variables. The desire for learning may be to satisfy intellectual curiosity, restore independence, prevent complications, or facilitate discharge and return to the comfort of home. Less desirable reasons are to please others and to avoid criticism. Gerontologic considerations. Most people are creatures of habit and are reluctant to make changes without understanding the benefit. Older adults may be creative in methods for incorporating needed changes in health behavior if the purposes or anticipated benefits are made clear at the beginning of the teaching session. Stating a belief that the older adult can actually make the recommended health behavioral changes and providing encouragement may increase the client's self-confidence and result in increased learning. Teaching clients with sensory impairments, again, make sure they're wearing their visual or auditory aids. Speak in a normal tone of voice. Clients with visual impairments do not necessarily also have hearing impairments. Increased volume does not compensate for reduced vision. Use at least a 75 to 100 watt light source, preferably in a lamp that shines over the client's shoulder. Ceiling lights tend to diffuse light rather than concentrate it in a small area where the client needs to focus. Avoid standing in front of a window through which bright sunlight is shining. It is difficult to look into bright light. Provide a magnifying glass for reading. Magnification enlarges standard or small print to a comfortable size. Obtain pamphlets in large 12 to 16 point print and serif lettering, which has horizontal lines at the bottom and top of each letter. Letters and words are usually more distinct when set in large print with a style that promotes visual discrimination. Avoid using materials printed on glossy paper. Glossy paper reflects light, causing a glare that makes reading uncomfortable. Select a black print on white paper. This combination provides maximum contrast and makes letters more legible. This also depends on the client's vision and preference. For clients with hearing impairment, use a magic slate, chalkboard, flashcards, or writing pads to communicate. Writing can substitute for verbal instructions. Lower the voice pitch. Hearing loss is generally in the higher pitch ranges. Try to select words that do not begin with F, S, K, and SH. These letters are formed with high-pitched sounds and are therefore difficult for clients with hearing impairment to discriminate. Rephrase rather than repeat when the client does not understand. Rephrasing may provide additional visual or auditory clues to facilitate the client's understanding. Insert a stethoscope into the client's ears and speak into the bell with a low voice. The stethoscope acts as a primitive hearing aid. It projects sounds directly to the ears and reduces background noise. Is the following true or false? Increasing the duration of teaching sessions may help in overcoming problems of attention and concentration in clients. This is false. Keeping teaching sessions short may help in overcoming problems of attention and concentration in clients. Motivation. Learning is optimal when a person has motivation, that is, a purpose for acquiring new information. Relevance of learning depends on individual variables. The desire for learning may be to satisfy intellectual curiosity, restore independence, prevent complications, or facilitate discharge and return to the comfort of home. Less desirable reasons are to please others and to avoid criticism. Learning readiness. When a capacity and motivation for learning exists, the nurse can determine the final component, learning readiness. Learning readiness refers to the client's current physical and psychological well-being. For example, a person who is in pain, is too warm or cold, is having difficulty breathing, or is depressed or fearful is not in the best condition to learn. In these situations, it is best to restore comfort first and attend to teaching afterwards. Gerontologic consideration. Begin the teaching session by connecting the new information to the older person's actual experience. The following teaching strategies are particularly effective for older adults: presenting small amounts of information at a time, allowing enough time for processing information, expressing confidence in the older adult's ability to change health-related behaviors, and using positive feedback. Learning needs. A learning need is the gap between what a client knows and has yet to learn. The best teaching and learning take place when teaching is individualized. For teaching to be most efficient and personalized, the nurse must gather pertinent information from the client. Second-guessing what the client wants and needs to know often leads to wasted time and effort. The following are questions a nurse can ask to assess the client's learning needs. What does healthy mean to you? What things in your life interfere with being healthy? What do you not understand as fully as you would like? What activities do you need help with? What do you hope to accomplish before being discharged? How can I help you at this time? Informal and formal teaching. Informal teaching is unplanned and occurs spontaneously at the bedside. Formal teaching requires a plan. Without a plan, teaching becomes haphazard. Furthermore, without some organization of time and content, the potential for reaching goals, providing adequate information, and ensuring comprehension is jeopardized. Potential teaching needs are generally identified at the client's admission, but they may be amended as care and treatment progresses. If ongoing teaching is necessary, furnishing clients with technology for telehome care, which is visiting clients electronically in their home for the purpose of seeing and communicating in real time, may be beneficial, especially for clients located in rural areas. A student nurse may work with a staff nurse or instructor in developing a teaching plan. Usually one or more nurses carry out certain specific parts of a teaching plan. This approach is most desirable so that a client is not overwhelmed with processing volumes of new information or learning skills that are difficult for novices to perform. Skill 8.1 serves as a model when an adult client needs teaching. That's on page 115 in TIMBY. General gerontologic considerations. During initial assessment of levels of cognitive function, clients may interact in socially appropriate manner. Clients may indicate that they understand material being taught. Ask the client to recall what has been discussed after about 15 minutes to assess retained information. Mental status examination may be indicated. Cognitive impairment, use a support person or caregiver to be present for teaching sessions. Older people may be creative in methods to incorporate needed changes in health behavior if purposes or anticipated benefits are made clear at the beginning of the teaching session. Begin teaching sessions with reference to the older person's actual experience. Project a calm demeanor in a quiet environment to decrease anxiety and distraction. Peer teaching or reinforcement in support group settings may be helpful. State your belief in the client's ability to change health behavior and provide encouragement. This is the end of the slideshow.